are. So I'm just going to give a little introduction to all the speakers. So we have Gloria Montiel. She is currently the senior grant writer for Ultimate Institute for Health Equity, as well as professor at Claremont Graduate University. She was born in Guerrero, Mexico, and grew up in Santa Ana, where she was the first Santa Ana high school student to have been admitted at Harvard University. As an undocumented student, she's faced challenges and was able to overcome these incredible challenges while successfully earning a degree in English and American Literature and Language in 2009. She also received her credentials in her master's degree in the Learning and Teaching program in 2011. And she didn't stop there. Her love and passion for learning has provided the groundwork for her to obtain her PhD in Education Policy, Evaluation, and Reform from Claremont Graduate University. We also have Dr. Marco Angulo. He is a core faculty member of Altamed's Family Medicine Residency Program. He graduated from the University of California, Berkeley with a degree in Chicano Studies in 1999. He entered medical school at UCI and participated in the Primalcy program and graduated in 2011. Since then, he also has continued to develop pipeline programs for high school, community college, and undergraduate students of disadvantaged backgrounds. And then last but not least, we have Dr. Dinora Chinchilla. She is currently a pulmonary critical care specialist at Harbor-UCLA Medical Center. She grew up in Lincoln Heights, California, and completed her Bachelor of Science in Biochemistry with a minor in Biology at California State University, LA. She then completed a post-bac and received her medical degree at UCI. She then went on to complete her residency in internal medicine at Harbor-UCLA Medical Center. So without further ado, Gloria, I'll give the mic to you. Thank you.
There we go. Okay, it seems like I'm sharing. Okay, so hello everybody. So this presentation is titled The Impact of Social Determinants of Health on COVID-19 and a roadmap, COVID-19 disparities and a roadmap toward health equity. I want to leave you with a little bit of hope at the end. And again, as Silvana mentioned, I grew up undocumented here in Southern California in Santa Ana. While growing up, I wasn't really aware that a lot of the conditions that existed in my community and with undocumented individuals actually had an impact on health and health outcomes. So when we think about social determinants of health, what these are sort of macro level policy systems in an environmental context that impact health. So we think about, for example, economic stability, neighborhood and physical environment, education, food, community and social context, and healthcare systems. And a lot of these things too are influenced by even additional things, for example, racism, social injustice, all of that, which create certain conditions that make it difficult for certain groups of people to have positive outcomes. So under each of these domains, there are certain things that determine, for example, different ability of individuals to thrive in their communities. Of course, employment and income, if individuals don't have the right resources, it's hard for them to be able to then afford housing, transportation, food. And if folks don't have transportation, it's hard for them to get to doctor's appointments. If they don't have housing, it's very hard for them to have stable conditions, especially if they're experiencing a chronic condition. So all these things at play, again, relate to health outcomes, including mortality, morbidity, life expectancy, healthcare expenditures, health status, and functional limitations. It seems that today, more than ever, and now that we have access to a lot more data and the ability to sort of map things, that we can tell people's life expectancy by the zip code where they live, right? And if we talk about, for example, I'm most familiar with Orange County, for example, someone who lives, for example, in the 92707 zip code, which is right on the border near Costa Mesa and then near Newport Beach, tends to live 10 years less than someone who lives in sort of those wealthier neighborhoods as well. The same thing that could be said about race and immigration status, because a lot of times in neighborhoods that have been historically disinvested, that have been regulated by policies that pushed out other people and created sort of these inner city type neighborhoods, conditions are usually worst off there. And these issues, these conditions end up having, especially right now, we can see the impact of that. So when we think about a pandemic, for example, like COVID-19, the health of everybody really depends on us being able to take care of our most marginalized and underserved individuals in the community, those who have chronic conditions, complex conditions, those of them who don't have access to healthcare, and literally everyone's health depends on that. If we have a family that doesn't have access to healthcare, that they don't have access, for example, to testing for COVID-19, it places other people at risk as well. And so we're thinking about how do these issues, how does food insecurity, how does social integration play into COVID-19? That's when we start to see healthcare disparities. So in this next slide, we can talk about a little bit about what those health disparities are. In Orange County, for example, Latinx patients are about 34.2% of the population, but account for about 47.7% of critical COVID-19 cases at UCI Health. And I should have included it here, but UCI, the School of Public Health, is actually doing a lot of interesting analysis and mapping, GIS mapping, and it shows that how COVID-19 got to Orange County was through the South County, where a lot of the beach communities are, because people were traveling, people who had access to sort of recreational opportunities. They are the ones that sort of it harbored in that region first. But then as we move along to really the stay away orders, then who were the people that were out? It was the essential workers, a lot of them low income, that work in the food industry, that work in manufacturing, gardening, caregiving. And so that is how then the labor force, the working class that we all depend on to be able to continue living through grocery stores, etc., then became more and more infected because of that high exposure and poor working conditions. And unfortunately, it is this population that also has the least access to healthcare services as well. So in LA County, what does that look like? So Latinx had about 46.4% of the total confirmed COVID-19 cases, which is the highest than any other race and ethnicity. And originally, there was a lot of the original research that Black communities also were really impacted by the mortality rates, despite having some of the lower rates of COVID-19 as well. So again, so that has shifted as the time has gone on, but also because of the population of Orange County as well, and sort of for example, the jobs that Latinx folks have access to. Again, it's just that at the essential worker type role, and with limited access to benefits as well. And so Latinx also represent approximately 69% of COVID-19 cases who were hospitalized, and they also had the longest range of length of stay, so up to 37 days, which is larger than any other racial or ethnic group as well. So these are some of sort of those health disparities, as how they end up being manifest in COVID-19. So when we think about sort of the role of COVID-19 and sort of it's bringing to surface all of these things, these weren't caused by COVID-19. Like COVID-19 didn't cause, for example, food insecurity. A lot of individuals right now are experiencing food insecurity. A lot of individuals are unable to pay their rent right now because of the fact that they have been out of work. But these conditions weren't caused by COVID-19. Again, if we think about, for example, economic stability and what kinds of access to employment our communities in low-income areas have, it's again that ability that they weren't able to pay their rent before either. It's just that now, with sort of that absence of work for long periods of time, it's Latinx, low income communities, and Black communities that are most impacted in terms of the long term economic effect of COVID-19, which will then result also in their it will prevent them also from being able to manage existing conditions like diabetes, and other conditions as well. So again, on this slide, so these are the disparities that exist. On the right to the left-hand side, highlighted in darker blue, we have the domains of social determinants of health. And when we look at the middle slide, I should have changed this. It's undocumented and other low-income communities of color that's where the risk factors are. For example, health and healthcare access. So there's limited access not only for the general undocumented population, but also for other communities during this time, because of transportation issues. Because what do we do now that buses, also present a risk, and individuals don't have access to reliable transportation, etc. The same thing with economic stability. And again, the essential worker base that low-income communities have access to are jobs with high exposure. And there's also limited economic opportunity or means during the pandemic to take care of other basic needs that families have as well. And unfortunately, this also means that within sort of the social and community context, there's limited access to mechanisms of civic participation. If we think about now, for example, some of the things that you hear in the commercials is this push for the census. Our communities in LA, and all over the United States, low-income communities of color, were the first hit and the hardest hit, and will have the longest impact in terms of economic impact of COVID-19. Now, in alignment with the census, it's also that the census determines the next 10 years of funding. And so if our communities have been hit by the economic impact, but then we don't participate in the census over the long term, that's going to even take away 10 years worth of funding from our community. So really this, again, and there's very limited infrastructure in low-income communities of color to be able to reach this population that sometimes does not participate for various reasons, including sort of intimidation, or again, issues with immigration, etc. And there's really limited knowledge and networks that can deliver that reliable information. And Dr. Angulo is going to talk a little bit later about the misconceptions that exist, but you have everything from namas ponte vaporu, just use vapor up and it'll go away, to like, if I go get tested, they're going to actually infect me, to the government's using this, it's not real, etc. So all of this happens in our communities because there's no infrastructure to deliver reliable information, because historically the government has failed our communities. In Los Angeles, for example, we have a region, Southeast Los Angeles, that's made up of communities that are heavily focused on manufacturing as the prime source of income. Education levels are extremely limited. About 80% or more of the residents speak a language other than English at home. So all of this presents challenges in terms of delivering culturally appropriate information that's not only understandable in Spanish, but also that is understandable in terms of accessible language through education. And again, and so pre-pandemic, there were already fewer opportunities for regions like Southeast Los Angeles, or in Orange County, Santa Ana, and Anaheim, educational opportunities. And now when we also think about what's happening with schools and that movement toward online learning for necessity, it's really difficult, especially when there's no infrastructure to support that type of learning in our schools, which are already under-resourced. Again, COVID-19 is only highlighting the impact of what happens when we disinvest from these communities and then we add on a public health crisis. So again, this is sort of shows that we need to address social determinants of health, not only in terms of if someone's needing like a housing voucher, let's help them pay a month of rent, but really transform the housing system to make it a lot more affordable for others. And we also think the composition of our families in this neighborhood and built environment. Oftentimes, because rent is so high, multiple families and multi-generational families have to live in a single household. I can give the example of my aunt and a grandpa's. It's my little cousins that are living there, ages 12 and 5, my aunt and her husband, and then my grandparents as well. And now my aunt was tested positive for COVID-19 and was experiencing symptoms. And at that point, what do? You have elderly individuals at that household, you have them and you have the children, and so how do you make arrangements to make sure that folks are able to self-isolate? And these are and these types of problems don't happen in other communities that have the accessibility of houses, that have the ability to, rent a separate motel room or make other living arrangements for them to have those necessary precautions. So again, this is the context in which sort of the policies and the systems and the environments that have made these healthcare disparities among Latinx, Black communities and other communities of color and low-income communities at that intersection. But we also want to discuss what does that look like, or once our patients actually come to the clinic in the middle of a pandemic. So I was gonna turn the mic over to Dr. Angulo.
Wow, it's always great to hear Dr. Montiel.
To give us some perspectives from the clinic.
Yeah. Hold on one second. Thank you so much for that. Every time you talk, I feel like you're following me in my clinic. I feel like, oh my goodness, she's somewhere, the camera somewhere. So thank you for that. I want to, all of you are going to be doctors fairly soon. You don't know it yet, but it's a conveyor belt. You'll be spit out in no time. But I wanted to take you back a little bit, if it's okay, to when this all started happening, and talk about some of the things Dr. Montiel was talking about, but also then hand it off to Dr. Chinchilla so she could you could see now from the clinic to the ICU aspect of it and what she's seeing there. But I still vividly remember it was in the middle of March. And all of a sudden we were sheltered in place, and all of us are thinking like, what the heck is this? We've heard about it, we've heard of it, we don't know much about it, we don't know how it's contracted, and you're thinking like, okay, so I got to go to clinic, right? And patients are coming in, they've been coming in sick, so then right away you think, am I going to bring it home? Actually, you start thinking, not will I bring this home, when will I bring this home? Because you're like, this is it. It's a done deal. So then when you go to work, you have a conversation with your family members. You say, okay, I'm going to go to work, because for me, I work for Altamed, and Altamed is definitely, it's a federally qualified health center, and it's the only place that I practice, and the only place I want to practice. And I have to be there for my community. So you start thinking like, half of you is there thinking like you're just freaking out saying, what is this? And the other half is like, I gotta be out there. So you have that conversation with your family, and then you tell your mom, I'm not gonna see you for the next couple of months. We'll see you later. We'll be Zooming, I'll show you how to Zoom and whatnot. And the reality is, you talk to friends, you talk to people also in these programs, and some of them are like, no, I gotta take a leave of absence. No, and it's just, you understand it, because they're like, I'm taking care of my mom. I'm taking care of my, my grandmother. I don't want to get them affected. So that was the mentality back in March. And you're seeing all this happen. And I don't know how Dr. Chinchilla did it, because you see all this happening in New York, where there's like a tsunami coming, and there's a wave coming in, and you're thinking like, oh my goodness, what is going on here? What can we possibly, what are we getting ourselves into? But I'm so proud and happy to be working for Altimed because we actually spun our clinics on a dime. We were really noticing that there was clinics popping up, the testing centers in Irvine, in other places that maybe had more resources. And our leadership, thanks to Dr. Brown, our infectious disease, and our CEO, Castulo de la Rocha, said, no, not in my community. And we actually, like that, all of a sudden we have 9 testing sites, all operational. We started with 15 test kits, 15, 1-5. And then we talked to the county and said, you know what, give us all you got. And we ended up getting over 200 test kits, right? So we actually, we streamlined it, we planned, do study, acted it, and we got this thing going. So I'm really I owe Dr. Brown a lot because she took leadership over that, and she showed us that, you know what, whatever it is, we didn't even know that we were going to get reimbursed or not, but we didn't care. We said, you know what, we need to take care of, if not us, then who's going to take care of our community, right? So that's what we kind of went into. That's what our main thought was. But then you start seeing these patients, and like Dr. Montiel was saying, automatically, patients are coming in, some asymptomatic, some symptomatic, and you're like, oh, they have COVID for sure. And you're giving them this paperwork. You're like, here, I want you to stay away from work, self-isolate, stay away for 14 days. And you're seeing, Mr. Sanchez, Senor Martinez, turn to him like, how could I stay away from work for 14 days? This is impossible. This is my livelihood. So it makes you think like the whole essential worker, non-essential worker, he is essential for his family, right? And for me, I was like, it just took me aback. Every day was just a heartache because then even social distancing, you'd be like, you know what? And when you're at home, isolate, make sure that you're away from everybody in your house. And then like Dr. Montiel said, patients would be like, well, I live with 3 or 4 families here. How am I gonna social distance myself at home? And it just completely breaks your heart on that aspect. Then you have a mother come in. These are all true stories. You have a mother come in, she's in the car, and she's got 7 other people in the car. She's tested COVID positive. And she has an elderly, her mother on the right, and all the kids in the back saying, oh, I want you to test all my kids because I tested positive. And you're thinking, oh my goodness. Okay, so you're supposed to be home isolating. And she's like, I'm the only one that drives. How could I get my kids here? So it makes you think about a lot of things and put things into perspective. And like she was talking about, you have patients that say, I didn't see you open that because I know that you guys insert the positive COVID test and you put it in my nose, and then then I'll get COVID that way. And that actually happened one time when one of my nurses opened the test, and one of the patients turned around and he looked and he's like, that one's open, I don't trust it. We tested him and he ended up being positive, but now you have him thinking, okay, that's it. They're trying to pass this thing on to me. So seen a lot. The patient with that stopped taking her metformin because she heard in the news that metformin and the COVID don't mix, and that it could make things worse for her. So, I mean, this is something that I'm going to take to you and ask you in your discussion groups, what do you do at that moment? What would you do? I'm not going to give you the answer of what I would do. Well, maybe later. But I'm speechless here, The next thing is you think about, okay, so our clinics are empty now. Nobody's coming in. Everybody's coming to that testing center. But I'm thinking, like, did diabetes get cured? Did all the vaccinations, are we suspending them? So for me, it kind of freaks me out that nobody's coming into clinic anymore. I know people have uncontrolled diabetes, hypertension. I know that our kids have to come in and get vaccinated. So what we did was we had to do telephone visits or video visits. and it's something brand new. Actually, this has been something that that actually sped up in the process. We were looking at doing this in like 5 years or 10 years. All of a sudden, in an instant, we started doing telephone visits and video visits. But our patients are my patients. They want to see the doctor personally. So a lot of them didn't take up with the video visits, and it's not the same, you know. So then we ended up creating a health navigator program, and I think for us that's been one of the biggest things we've done, and it's making sure that we have pre-med students that are actually coming. They may be in your class pretty soon. Actually, come over, outreach to these patients, and make them feel as comfortable as possible. Doing wellness checks, making sure that they are taken care of, making sure that they know that El Doctor Angulo is thinking about them, and making sure that they either have a telephone visit or they have a face-to-face visit. But that's been working out probably the best out of everything. But now seeing the effects and seeing now, it's like the second phase of it. Today I saw 20 patients. About half of those patients have now had their life altered in some way or form because of COVID. And I'm talking about deaths in the family. Now you're starting to see, oh, I lost my sister-in-law, and it's just so sad to see that. We have now people that have had COVID and have PTSD because they're still going over those symptoms. And they feel like they still feel like, oh, I still have chest tightness. And I'm like, yes, we have to get through this. We have no idea what this, the sequelae of this. And also anxiety of people coming in and being isolated, being alone, or feeling that they're going to catch it. And for us, that's something that we need to make sure that our patients are taken care of, and our patients have every question answered for them. Today, I had a patient that he lost his business. He was selling music at a swap meet, and he said it's closed down. Everything has been closed down. And I go, so then do you think after this you can get it back going? He goes, no, it's done. It's done. So thank God I had the health navigators. I called them and I said, hey, can we work something out with this patient? And right away they came in and they're going to help him adjust, make sure that he has all the resources possible. But it's definitely a new normal, and I think we're learning every day, new things in this process. But I'm excited to see your discussion because you're the leaders of this. You guys are all leaders here, and I want to know what that discussion leads to. But pretty much right now, that's the process that we're going through. I wanted to pass it over to Doctora Chinchilla because I wanted to make sure that you see her point of view as well. But thank you.
Can you guys hear me? I'm assuming you can. Yeah, so just to kind of, for the people who rolled in a little late, I actually just completed fellowship at Cedars-Sinai in June and was in the ICU for 3 months back to back, actually. And, I am sitting here and listening to Gloria Montiel speak and give her very detailed background information of why our patients are being affected so disproportionately. And it's exactly those things. And you sit there in the ICU and you go through your list of patients and they're all similar. They're all in their 40s or 50s. They're over 80% of them were Latino by the time I left. So you're talking about Hernandez, Fernandez, like every Latino last name you can think of. With diabetes, with hypertension, with obesity, and coming in with COVID-like symptoms because they worked at Taco Bell and they got exposed. They were working at Numero Uno or Northgate, or they live with 3 families and there was somebody in the house that got exposed and they either didn't know how to self-isolate, didn't get tested, and here we have somebody in the ICU who's on a ventilator. So everything she spoke about is what we see in the ICU. And she quoted, I believe in LA County, over 60% were Latinos. So I'm in particular in my hospital, there was way more than that. I left and I was like, which one is not Latino? Like I started, even myself, confusing, like, wait, we have a Hernandez on that side and another Hernandez on the side. And so, and the stories were blending because they all had the same history. I feel like for people who are working in the ICU, nursing staff, RTs, physicians, residents, attendings, a lot of us have, I think, have become very emotionally drained. Not that it's not emotionally draining to be, you know, it's just to be out in the clinics and out and doing outreach but we have our own perspective to like seeing all the death, seeing all the, Marco says, you know, he's getting patients with PTSD, and it's probably our patients who ended up in the ICU on the ventilator, sedated for weeks. And now, you know, thankfully we're off the ventilator with all these sequelae, and now they have to go see Marco. And he has to help them get through this horrible experience. And I can't say it's been easy. It's been probably, being in the ICU is obviously sad, like most of the time, right? You lose a lot of patients. It's very high acuity, but it's different when it's the same thing every day for a disease process we don't understand, for a disease process that potentially could be preventable by using appropriate PPE on the community, or by having just the resources for these patients and the right to have healthcare and that right to have access to healthcare, so that they don't have uncontrolled diabetes, so that they don't have uncontrolled hypertension, so they can have access to healthier food and access to parks, so they can work out and not be obese. And so all of these things that we could have prevented before, like Dr. Montiel mentioned, are just being highlighted with COVID-19. And it's just sad to see all these really sick patients unable to see their loved ones, unable to hold their hands, unable to, I mean, I'm talking about patients coming in, like they decompensate so fast. Within hours, I would say 4 to 6 hours, they're from like being on room air to like needing the ventilator because they're maxed on high flow. Our non-invasive oxygen capabilities, and they are still satting in the 80s, and you have to have a conversation with them about putting them on a ventilator. And then you're like, well, I want you to speak to your family before you're on a ventilator for 2 to 3 weeks, and who knows, maybe even longer. And they look at you with like, why? Like, I'm short of breath, I know I'm sick, but why 2 to 3 weeks? And you're like, I'm sorry, this is what we've seen. And I still vividly remember my last day in the ICU, like it was yesterday, because I graduated at the end of June. My last day, middle-aged man, Latino. Again, it took like, they called me from the floor. They said, patient, you know, his oxygen requirements have been going up for the last several hours. And I said, you know what, put him on high flow. I'll come by and check on him when I get a chance. I went to go take care of some acuity things. I knew I was going to circle back to this guy, or that he was going to end up in the unit. I knew it, because that's the pattern they've shown. And I get a call 2 hours later. Oh, patient's maxed on high flow. He's now satting in the low 90s. And I'm like, oh, here we go again. So patient gets brought up to the ICU. He gets into the room. 10 minutes into the unit, he's satting 82%, maxed on high flow and a face mask. And of course, I'm like, he has to get intubated, right? And I'm like, okay, well, the first thing I always do with these patients is like, they need to FaceTime their families. I don't have their wife there. I don't have their daughters there to be like, hold their hand, tell them I love you, tell them that they won't be able to speak to him for like 2 to 3 weeks. Just imagine that. If your mom, if your sister, if your loved one, you can hold their hand. How awful is that? When have you ever seen this? Never. We've never seen this in history. And he tells me, okay, let's call them. We call them on, thank goodness that his daughter had an iPhone and we could FaceTime, because there's been situations where nobody has an iPhone and we can't do that and we have to do it just over the phone. And I speak to the wife, and you can tell the wife was like wanting it, just crying, but she was just holding it back. And the daughter, and she was like, dile lo que me dijiste. And I'm explaining, patient can't see my face, right? I'm wearing an N95, I'm wearing a shield, I'm wearing a hood. Like, they can't even tell who I am. All they can hear is my voice. And in Spanish, I'm trying to describe that I'm gonna put him on a breathing machine for 2 weeks, maybe longer. I don't know how he's gonna do. Let's hope for the best. We're gonna take care of him as you know, as best to our abilities. We're probably one of the best centers in Southern California. And that we're gonna do everything we can to save him. And he looks at me and he says, I don't wanna talk anymore. And the wife starts crying and the daughter starts crying. And then they say their goodbyes. And then I ask him, I held his hand and I asked him, are you religious? And he says, yes, I am. I said, what religion do you practice? And he said, I'm Catholic. And I said, in Spanish, I said, ¿Quiere que recemos un Padre Nuestro? And he tells me, después de que me pongan en la máquina. He's like, por favor, no me deje que nada malo me pase. You know, like, I am his comfort at that point. I am his person when it shouldn't be this way. And it's really hard to see. I mean, I can tell you dozens of stories similarly to this. I've as a Spanish-speaking physician and being the minority in an ICU, I'm going to tell you, among all my fellows, among all the faculty, and probably over 90% of the residents, the only one who's fluent in Spanish, the only one that understands that what it's like not to have food on your table, not to have a park to go to, that you have to play in a parking lot where your cars are parked because that's all you have in an apartment complex, where you have a 1-bedroom where 2 or 3 families are living. I mean, I went through that and I understand that. And be able to be like, I understand what you're going through, what you've been through. And I promise you, I will do everything in my hands to give you back to your family. I'm gonna start crying. I don't wanna cry. I'm such a big baby. But like, it's crazy. It's crazy times. We need all you guys out there, like Marco said, we need you guys to come out there. You guys understand the disparities. You guys are a select group of people who decided to go into programs to become leaders in communities who don't have access to healthcare, to make a difference. And I can't say it's too late. It's affecting our patients already, right? But we can still move forward. We can still make a difference now and in the future generations that are to come.
Thank you, Dr. Chinchilla. I definitely teared up as well. And so what that leaves us with is, how do we rebuild, right? Our communities are being impacted right now by this terrible pandemic. They're the ones that are dying at higher rates. They're the ones that economically it's going to be harder for them to recover. So how do we build in a way that's not to what it was before, but something better that really builds community resilience over the long term, to make sure that whatever other health crisis comes knocking on our door next, hopefully not ever as bad as this, it doesn't impact our communities as this one did. So as we're thinking about access to vaccines and future treatment for COVID-19, how do we make sure that it gets to the individuals who most need it and who can't afford it? We're here on the news sort of the prices of some of these proposed vaccines, and it's ridiculous. And so then how do we not only make sure that we mobilize this access to vaccines and treatment, but also to economic opportunity that will allow individuals to take care of themselves, to have access to healthcare? How do we sustain the community's education right now in terms of their children? And again, ensure active participation in census, which is going to bring resources for the next 10 years. And also a critical election coming up as well for us with a lot of potential to really impact policy in the future of our communities. So as we move toward health equity, which is very different from those social determinants of health, where we have integrated access, integrated methods of caring for our communities at all levels, what can we do? Ultimate leverages its clinic infrastructure as hubs for civic engagement to mobilize patients to really address the social determinants of health, not just social needs. We engage in voter engagement, nonpartisan voter engagement, in developing community leaders, in developing the next generation of physicians to not only take an active role in the clinic, but really how do we advance policy that is equitable and protects those rights and in the neighborhoods and the programs that our communities need as well. So I know we're running over time a little bit, but I do want to lead you with how can providers take action? You all are going to play, as we have heard Dr. Angulo and Dr. Chinchilla, a central role in literally saving lives. But beyond that, how do we prevent individuals from being at that point where their life needs saving to begin with? All it takes, research has shown that providers are among the #1 trusted messengers in our communities. All it takes is 1 minute for you to huddle with your team to remind them of the importance for civic engagement and engaging in transforming social determinants of health. All it takes is your patients looking at your I voted sticker or I got counted button to be able to mobilize themselves and to get your example in participating in this. And as you're out in your communities as well, as you're volunteering, wearing your affiliation, the fact that you're a doctor moves mountains in our communities, because again, you are the healers within our community, and that is what our patients see. And as you see here, we have Dr. Ilan Shapiro and then our COO, Dr. Efrain Talamantes too, taking a stand for what is right in a way that recognizes that a lot of these social determinants of health are kind of spiraled or exacerbated by some of the most basic violations of human rights. And so making sure that you're able to take that stand for when it happens. And then the other piece of advocacy and how you can have an impact in the future too, in building sort of conversations around health equity. So right here on the left-hand side, I left a plug for the interview with Dr. Chinchilla and her experience as well. And the podcast in general, the Institute for Health Equity from the Front Lines. Dr. Angulo, Dr. Talamantes, and Dr. Roger Liu here at the Institute for Health Equity at Ultimate are trying to bring the voices of those most underrepresented in healthcare and really elevate the ways in which we also create health equity in our communities. So with that, I'm going to leave my contact information for the future, but I do want to open it up for questions now as well.
If anyone has questions, please feel free to unmute, turn on your camera, and you can direct questions to Dr. Montiel, Dr. Chinchilla, or Dr. Angulo.
Hi there. Hi, my name's Shelby. I have a quick question. I'm actually in STARS cohort. I'm in the Prime Health Equity program at UC San Diego. Nice to meet you all and see you, and thank you so much for all the presentation so far. My question, one of my vested interests is healthcare as a human right. I think that the patients that you've mentioned so far in this, presentation, maybe who don't have access to healthcare or have Medi-Cal or any other form of healthcare should have just the same access to I do, having SHIP, the SHIP insurance. It's like a great quality insurance. So I fundamentally believe we have to acknowledge that that is something that should be fought for. And I was actually the other day on a Healthy California for All commission call. There's a commission meeting monthly where people are coming together, experts, health policy experts are trying to formulate a policy for universal healthcare in California. They don't quite know what it looks like, and they actually had a presentation on COVID health disparities. But what I noticed throughout the call was there's a intention to focus on understanding and looking at the disparities, but not naming the reason for the inequities. So the social determinants of health and whatnot. So I guess I'm just kind of stating this to say, what do you all think, based on your experience as physicians and students as well, would be the most productive or successful way to engage medical students and doctors to really fight for the basic universal healthcare right? Because I know it's not the only thing that's going to solve healthcare disparities. There's obviously issues of geographic location and food and housing and racism and all these things, but I do think it is important that everyone should be able to go to the doctor and not have to be afraid of doing so, regardless of where they were born. So what do you all think would be the best way to mobilize medical professionals to fight for that basic right?
So Ultimed is actually created a model for training physicians within our clinics to be able to be familiar with those tools. We also created an app that makes it easy for our physicians and anyone working throughout our health system to be able to, through the app, for example, send a letter to Congress, etc. And then the other thing that physicians can do is really invest and follow all policy related to federally qualified health centers, because at this point where we don't have universal health care for everybody, FQHCs are those clinics that are able to serve everybody. And unfortunately, every time sort of budget comes to the table in Congress, FQHC funding is always on the chopping block. So again, right now, for example, our government relations department earlier sent out an email giving us direct instructions and a link to be able to give our piece of advocacy to save or to protect this legislation. The other thing to note is that across the state, there's also trade organizations for physicians. For example, there's one, I can't remember the acronym is LACMA, not the museum here, but it's a advocacy organization for physicians. And so this is sort of a mechanism that elevates the priorities, the policy priorities of physicians, and it's a great way to sort of have more impact as a block, as individuals that are decision makers and are especially experts in a particular arena, in this case healthcare, to actually make their voices heard in Sacramento or in Washington as well.
Shelby, great question. And I thought Dr. Montiel answered it wonderful. You want in? We want to work with you. Absolutely. There's 24 people here, minus 1, 2, 3, right? So 21 people here. This is a revolution. I'm telling you right now, I have never, ever felt so strong right now in my entire life with healthcare. With working at one place called Ultimed. We took it over. Prime took it over, LMSA took it over, whatever you want to hear. Our COO is Dr. Efrain Telemantes, right? He's the one running that show right now. We're all there. We all know where we've come from. We all know what we've been doing. So Shelby, if you want it, I'm going to give you my email, phone number, whatever it is. We need your spirit, we need your help, and we're in.
Yes, please. Thank you. Absolutely. And you mentioned it was LACMA, that was a physician organization. Okay. I will look that up.
And there's an equivalent too at the California level. That's just the LA region, but there's one that also does statewide advocacy.
Okay, thank you.
Hi, so first of all, I want to say thank you so much for this presentation. So my question is for anyone. So based on your experiences, how do you go about convincing people to wear PPE or get vaccinated who are resistant to these preventative measures?
I'll let that type of doctors.
Yeah, you know what, Dr. Chinchilla could answer in hers, but it's definitely, it takes a lot of motivational interviewing. It takes a lot of like, okay, well, let's take this. And what's making you feel uncomfortable about this? And why would, tell me a little bit about what you're thinking about those conversations. It takes time, you know, as for people that maybe say, this is my constitutional right, I don't want to, you know, that's for me. It's if you could figure something out with that.
It's very frustrating. I think that's the very frustrating part about it.
Yeah. As far as my patients are concerned, but go ahead. As far as my patients are concerned, it definitely takes sitting down with them and going over that process over and over and over again.
It can be very frustrating. I mean, I'm sure you guys are all seeing the social media. I mean, I've had arguments with family members. I've had arguments with friends. I mean, I've had arguments with other healthcare professionals. I don't know if you've had the same experience, Marco, but you see them on social media posting these pictures, these gatherings, and I'm like, whoa, wait, what is this? Like, there's more than 10 people. You guys are not 6 feet apart, and none of you guys are wearing masks. Like, and then people get offended, you know. So I try to be as politically correct as I can. I usually say, you know, remember that we're in a pandemic. I know it's very frustrating. I mean, we're all in this together, right? We all like can't go anywhere because we are afraid of exposing our families, exposing other people. I don't know how you feel, Marco, but like, I don't even want to go to the store because I'm like, if I got infected because I've been in the ICU and I just brought somebody like 3 days ago, I might infect somebody at the store because I touched something, even though I'm like super like, try to be careful and try not to touch my face. Like, what if I made the little mistake? I didn't notice it and I just touched a fruit that somebody else is going to pick up. I mean, I understand the severity of that. I think the way I approach it is that I try to see it from their perspective, and I try to say, you know, it's sometimes one mistake that can cost you not only your loved one, but someone else's loved one. Like, and I try to share stories sometimes, and that seems to make people feel bad. Because if, for example, the story of having people in the ICU not able to see their families, I mean, that's terrible, right? Like, and sometimes it works and sometimes people don't want to hear it. So, I mean, that's a very good question, and I wish we had an answer for it. I think it just depends on the type of person that you're speaking to and their arguments.
Thank you.
Hi, I'm Kavya. I have a quick question. I just came off of my ICU rotation about a week ago. So Dr. Chinchilla, everything that you were saying really resonated with me. There were a lot of tough experiences, especially because I was the one med student who spoke Spanish and was able to with my patients. So I was the one updating all the families for our 20 ICU patients. But the real problem actually, like Dr. Montiel pointed out, like being visible and like trying to reach out to your team and fellow physicians and making them aware of these issues became really important to me, because even during lunchtime conversations, I heard them saying things like, these are terms that I'm just learning as a student and I'm appalled that they're even present in the medical setting, but like TBD, total body dolor, or HP, Hispanic panic, and these are still being used. And I had a nurse, because primarily our patients were transfers from El Centro Hospital, which is about a couple hours away. And she was saying it's because these patients like to fiesta a lot. And I turned around to her and I said, I don't understand what you mean. That's really offensive. And primarily the people in Huntington Beach are not Latinos, so I don't know what you have to say about that. I kind of just went there. And I'm just wondering, like, how do you guys step up to the plate and like be politically correct and engage them in conversation? What more can we be doing to engage them in conversation regularly? Because it's horrible that I still have to make these comments as the person that's bottom on the totem pole in the medical hierarchy.
I'm glad you actually brought the hierarchy up, because I think that really is important. As you rise as a resident, as an intern, as a resident, as a fellow, or as an attending, you'll see the difference. And it sucks that this is the way it is, and that I wish that the culture of medicine was different, but you continuing to be successful in your path in medicine gives you more power to stand up for your own patients and for this population, right? I mean, I would do it as a med student, as you did. You know, I'm so proud of you that you stood up to somebody who's, you know, a nurse who has probably years more experience than you, but this doesn't mean that it's okay for her to make comments like that, right? So I did the same as you, and I continue to, but I see it less and less. And I think I see it less and less because now I'm the senior fellow who's in charge of the team, and the nurses respect me. And, you know, I'm in a different hierarchy now. I am a person of color who speaks Spanish. I'm very outspoken about how mad I get when the interns don't call the family members, how upset I get because I've been giving my cell phone to families, which I never did before. So people text me, hey, like I'm off, I'm on nights. Hey, the medical team didn't update me for 3 days. And I'm the person who rants into the ICU, and I'm like, well, why did this family member not get updated for 3 days? What's going on? Like, the intern needs to know, the senior fellow needs to know, the charge nurse needs to know, like, this is an issue. We have over 90% Latino patients. Like, these are our responsibilities. Treat people with respect, you know? So people know me to be that way already. And so you have to let your presence be known from the beginning. So our patients get treated with respect. And then you open that bridge to conversation, right? You're like, you educate them and you say, no, we are not having fiestas. We're actually part of the central working class. And this is why we got exposed. The reason why El Centro became such a hot spot is because all our patients at the border were crossing to go work. And then they came back and got sick. And because there's multiple people living in small apartments because they don't have any options because they can't afford rent on their own, they're spreading it. And because we have diabetes, hypertension, and obese, they're getting really sick and ending up in the ICU. So again, like, I feel like you have to educate them. Although we get angry and we get upset about it, we have to meet them and educate them. Education. But I'm a very passionate person. If you ever meet me, sometimes I can become a little less politically correct, but I try my best.
It's okay. I think I went off and did a little swearing myself during one of these conversations. It was like a family hadn't gotten updated for a while, and then everyone was upset that the family wasn't pursuing palliative care. And I said, why the F would they agree to palliative care when they don't know what the hell is going on with their patient, like their family member? I just got really upset, and then they just all kind of were quiet for a second. And then they were like, we should update our patients. And I was like, I'm just going to sit in the corner again. So
No,
yeah,
good for you. Good for you.
I think we should continue being passionate. And like, if you get reprimanded for it, I feel like it's okay, because at least you stood your ground. It's not like you did something wrong. It's that you stood up for what was right, if that makes sense.
No, yeah, absolutely. Trust me, I've gotten in a lot of trouble during my
Yeah.
path.
Yeah.
Kavya is a Kavya. I pronounced it correct, yes?
Mm-hmm. Kavya.
Yeah,
Yeah.
so thank you for sharing that, you know, and I agree with that. And I agree with, there's going to be a couple of roads you're going to hit in your life, right? You're going to hit one road and say, you know what, this is a part of the hidden curriculum. This is part of the medical establishment, especially, and you're at UCI, right? Is that right? So then every institution, you're going to have a teaching institution, and that's the culture that you're going to get into. There's great people there, great people. And there's people that you're going to be like, unbelievable. Did you just say this? And this patient you're going to be operating on, or you're going to be intubating, right? So there's two roads. Either one, you can be part of that and mold that change. I think this is where Dr. Chinchilla has decided to go because she's going to be starting at UCI. You'll be working with her over there, right? Or there's another way that you'd be like, you know what? I don't want any part of this. I'll just do my private. I'll just go on this over here, and I won't even deal with it. That's up to you. Nobody will fault you with that, right? Now, why I keep on saying, and you guys are like, yeah, how important you are, how important you guys are. You know, you guys have the it. You guys got into these schools of prime. You guys are prime. That not only to the medical schools, to California, that's a huge, big deal. You're not just physicians, you're physician leaders. So that's something that I want to make sure that I keep on telling you. So what do we do at Ultimate? What do I do at Ultimate? We create a residency program. We're going to be teaching this the right way. Next stop, we're going to create a medical school. It's coming soon, maybe 5 years. So, but it's things that we have to do to get back our narrative. We're telling the story now. We want to make sure that we're telling it our way. You know, so I applaud you. Thank you so much for sharing.
Thank you, you guys. It gives me motivation to continue doing this and not get bogged down by the other voices and the hidden curriculum.
Well, I know we're running a little bit over time, so I don't know, Silvana, what the next steps are.
Hi, I'm not sure if Savannah's Wi-Fi is being a little slow, but now we're going to transition into breakout rooms. And so we are running a little bit behind schedule, but that is only because we've had really good discussions so far. So we're going to break out into 3 rooms, and I'm going to try to be able to put one of the speakers into each of the rooms. And that way we can kind of have more intimate discussions with everyone. So I will be trying to attempt to do this right now. And you should see yourself in a breakout room, and I'm going to be moving around the speakers.
Should we be flies on the walls?
To have to join the discussion as well. And so in the chat, Silvana has posted some kind of just like guiding questions, but feel free to let the conversation flow however you like. And if Silvana and Diana want to interject, I think all rooms are now open.
I got bumped back.
Oh, you did? Oh, it was because you and Dr. Chinchilla were in the same room. So I'm going to move you to a different breakout room right now.
Thank you, Star.
You're welcome. Thank you.
I think I have to go here somewhere, right? And then, we're joining breakout room. Yes, I got it.
Okay, great.
I wasn't sure who's leading the room questions. Did everyone get access to those in the chat? Okay. I can't see. I'm using the access from my phone here, so I can't really see who else is like logged on. Do you guys have access to the questions?
Yeah, I do. Sorry, my internet is like being very staticky, so I may try to move a little bit and see if that'll help. So hi, everyone, my name is Deanna. I'm a second year at UC Davis.
Hi everyone, I just wanted to pop by and check out how your breakout room is doing. Please feel free to let the conversation flow, however, and you can like definitely jump back into the main room if something goes wrong, and I can try to come back and help.
Should we try to answer some of the questions that you posted for the breakout?
Yeah.
Okay.
Don't have an answer to this question, and I think it's a really difficult question to answer. I mean, not just when it comes to somebody not wearing a mask, but more generally speaking, like how do you
Hi Marlies, thank you for joining us. Hello? Hello, I think you're muted. Okay, they left. Welcome back, everyone. We're just going to give another minute for everyone to come back from the breakout rooms. I think we have one more group because I don't see Dr. Angulo.
It's probably already inspiring them to go out right now.
Oh, they're still in their breakout room. Okay, they're coming back.
Hello, Star.
Yes.
Hi, my name's Ashley. I'm a guest today joining with Silvana, and I was in the breakout room 1,
Yeah.
and my phone died. May I please be added back into the room?
Oh, we just actually ended all the breakout rooms, so everyone from room 1 should be back here somewhere.
Okay.
If not, they're coming back. So I'm so sorry that happened.
No, I just wanted to say it was a pleasure to listen to what everyone was sharing, and Dr. Angulo, he was sharing something, and my phone had died, but I appreciate all of your time today. So thank you.
Okay, I think everyone's back. So in our last few minutes, could we have maybe one representative from each room share what they talked about? That could also be the speakers. I know we have at least one speaker in each room. That might be the easiest way to do it, actually.
Could the speaker select the person?
Yeah.
I was gonna say, I nominate.
Yeah, if you guys you've done a lot of talking today, so if you want to pick on one person, that would.
Where's my Shelby? Where's our Shelby? Our team Shelby.
Oh, I know. I nominate Tracy Samaniego.
Oh, hi. Yes, mute, right. So we were in breakout group 2, and we were, our last question that we were actually talking about was how likely are you to speak about these things, with friends, family, or just people that you're around all the time. And I was describing how when you go through this kind of disparity personally, it's part of people your family, your friends, your own community groups. It's almost hard not to talk about it. It's very difficult to detach yourself from not speaking about who is going to speak for your own community. It's like I would, as a person, I'm very upfront, also very passionate, and I can't not stick up for myself. So how much more so would I not speak up for my parents, my cousins, my community that is going through something that I've gone through myself. So that's something that I think when you embody it, you will carry it out. You will carry it out more. You'll be able to really touch on the points, and maybe even like Dr. Chinchilla was saying before we went into our breakout rooms, is understand where people are coming from, and then be able to speak from your own perspective, but also speaking almost like their language, so that you can kind of not just get your point across, but get the point across of how important it is to stand up for the ones who can't be spoken for. Because I have a voice. I am very privileged to be able to be educated and have immigrant parents that fought tooth and nail for me to go into a career that is going to change my community. So why would I not speak about it? Thank you.
Thank you. I think Shelby's coming back because she's having a little bit of computer difficulty, but do we have a representative for group 3?
I'm going to ask Chris Turan if he can report for us.
Chris, so some of the stuff we talked about first was how do we reach out to people that that maybe are not wearing masks, or not following the guidelines, and we talked about some of the better ways are not to look at it really like as an adversarial thing, and to kind of just appeal to them and and taking into consideration that some of the stuff that that they may be holding on to that's holding them back from following the guidelines is social. Like maybe they're, Alexi said it really well, maybe they're afraid of not only like changing their minds, but also losing the social connections they made because of because of like their view that they have and their connections they have with the people around them. And so sometimes you also have to like change like social circles and not just like an individual's mind.
Thanks, Chris. So I just got a message from Shelby that her computer died and she's very sorry, but she enjoyed everyone's discussions and she says she's sorry that she can't do the recap. But Dr. Angulo also nominated Kavya, and I think Dr. Chinchilla has to step away. So if she's still here, thank you so much, and good luck taking care of your kids. Okay, Kavya.
Hi, for group 2, we talked about just like the first question alone, how COVID-19 is really bringing out the health disparities that exist already. And I think I do want to bring up Shelby's point because she was, and Dr. Angulo first brought it up. He was saying that like, where are these patients going to go? That's the first thing that happened with this pandemic. It's showing that, you know, we need to address the fact that patients aren't getting proper care because they don't have access to it. And it's showing us that our current healthcare system doesn't work and we need to be doing something about it. The current insurance system doesn't work and we need to be doing something about it. The other really important thing that we touched upon is the way that we use language to describe our patients that have not received the best care, trying not to use the words that like, oh, they don't do this or they don't do that, but trying to notice like where the differences can be in each community. In certain cases, yes, it might be true that maybe a white person is wearing a mask and maybe a person of color is not wearing a mask. But it also, as we have seen, can be the other way around where a person, like a Latina person will be wearing a mask, but a white person on Huntington Beach won't be wearing a mask. So being careful with how we generalize these subgroups is also very important, and the language that we use is very important. And Shelby actually put a great article that I had a chance to like quickly glance over about terms that we can use instead of using the words marginalized, use value, instead of using like, there are a lot of terms in there, but it really opens your eyes to how we should be treating individuals who have not been properly looked at in the healthcare system, and how COVID-19 is bringing all of that about, even within like the Black Lives Matter movement, like showing that these lives matter, and that's coming about in this pandemic because we're seeing those big disparities. That's a generalization of what we talked about, but I don't know if anyone else has anything else to say.
I thought it was well said.
All right. Well, does anybody else, before we wrap up, thank you so much for those that volunteered and wanted to and represented their groups. We just wanted to give one last opportunity for anybody who had any last minute questions for these speakers.
I actually had a quick question, if that's all right.
Yeah, go ahead.
To Dr. Angulo. You mentioned briefly during your talk that Ultimate has had to roll out telemedicine more quickly than they intended to. And that has been great, but at the same time, it seems like it's been a little bit of a double-edged sword in that a lot of your patients are missing the personal interaction with their physician. What other barriers do you predict we're going to see with Spanish-speaking Latino populations when it comes to telemedicine versus like the traditional physician visit?
I see it already, and I think that Altamed is definitely working on this, where actually the video visits, now they're going to transfer the telephone visits, because we do the telephone, to now video, so we can get reimbursed for video, but not telephone, right? And what Altamed is doing is signing everybody up on the My Altamed portal, where they actually have to have a video conference, kind of go through their electronic health record, and we have Epic. I see that as being an obstacle And we already talked to the leadership and everything like that. That cannot stand in the way of our patient care. So if Mrs. Ramirez, 91-year-old, does not have an email to sign up for My Ultimate portal, then what are we going to do about it, right? So there's great opportunity to actually use everybody has this. Everybody has this. And actually, there's a program called Doximity and DoxyMe that you can actually log on to, and instantly I can send them a code, and they just click on the button, and we can see each other. So those are other options. So we've asked Ultimate, our leadership, to be very cognizant of this next step. As far as nothing replaces those one-on-ones. You know, that's where you get the nuances. You get to kind of see the patient. I'm a hugger. I hug my patients, right? So it's been a big change, but I think it's the new normal. We call it the new normal, and we're developing tools right now as we speak. 60% is telephone video visits and 40% is walk-in. My clinic, I would say 80% is walk-in or face-to-face, and 20% is televisit, only because I've had my patients a lot longer. And we try to make it as safe for them as possible. We want to make sure that we're using the PPE so they're protected as well as much as possible. So creating that environment that they can come in and they know in Ultimate, we're not going to bunch them all together, and we're going to safely space everybody and make sure that they have appropriate distancing and make sure that they have the appropriate care. For us is the next. We're doing that now, but making sure that we tackle that on. But I do see the Ultimate portal as being, because you have to have an email.
And do you foresee telemedicine being a big part even after the pandemic's over?
Yeah, that's the new way of medicine. But see, the thing is that, okay, so this is a great thing about it, is that I can actually look at a rash on my phone of a patient, like, boom, I know that's ringworm. Or I know. So they don't have to come in anymore, right? So it's absolutely a wonderful thing. Or even get the symptoms, and I'm like, this is what you have. You don't have to come in. Or for medication refills, right? People are like, oh, and you just check the lab, and you're like, oh, yeah, I'll refill that, the insulin. I'll refill all these things for you. So once again, it's cutting the barriers down from like traveling, taking 3-4 buses to get to the clinic. You know, this has been wonderful, right? So it's definitely a plus on one side and a plus on the other side. So we're going to definitely use this for our patients' advantage. Yeah. Great question.
Thanks for the answer.
I have a question for Marco. I'm just curious, what kind of discussions are you having with those families that are like 2 to 3 families living in a home and somebody tests positive?
I was hoping you would figure that out in one of the breakout rooms. So
we didn't discuss it, and I was curious what you've come across.
You know, think about it. What can you do?
I mean, I just think of it like personally, like having lived like that with 2 or 3 families, and I just don't see that as a possibility. I feel like you can be safe, try to encourage, continue to stay at home if you can, wear PPE if you can, but it's impossible to really isolate yourself in that setting.
Especially when you share rooms with someone. So then usually it's like, oh, you can go into that room, that's your room. And then if you have 2 bathrooms, then you can use your own bathroom. They're like, Doc, tenemos un cuarto y tenemos un baño. Y eso es todo. And you're thinking, okay. So then what I do is I go back to, which you guys probably know more than I do, the motivational interview. I go, okay, you tell me, what can you do? How can you do this to make sure? And then they'll start, because they know their environment better, right? So they'll start giving me ideas like, oh, I could do this, I could do that. And then I'll start adding in why don't we do that? And make sure you wipe down. So that's the approach that I've taken, and patients are very creative, for that. It's so funny though, because you'll get a group of 4 people or 5 people that roll up and they get tested, and they're all together and they're all like hugging each other going, we all have COVID. And then 2 are positive. The ones in the back seat are negative. So I'm like, what is going on? I would just assume everybody was positive, right? So, and don't get me started with now the quarantine, because once that you're positive, you quarantine for 10 days. But if you're taking care of that patient, so then if you're taking care of someone, you have to not only take that 10 days, you have to add 14 days to your schedule. So you get penalized for taking care of somebody with COVID. Those are the new CDC guidelines, right? So then you're out for 24 days at work because you might have tested positive. You might be positive on the last day. So those are the things that I'm asking for your help, you know? Absolutely. Oh, good question.
Yeah, and
Yes.
I think it comes from experience and getting to know more patients, right? And the stories that you're going to be listening to. And I'm sure, like, as you are experiencing all this, like, you'll develop your own way of motivational interviewing, your own way of getting to the heart of, like, what's really going on, and how you can help them take a step forward with you.
Yeah, thank you. I'm gonna plug this again. We're with, you'll get, if you want to spend more time with Gloria in the research department at Altamed in doing this type of research, if it's in your prime project, I know you guys all have a prime project, we will help you. Don't worry, you don't have to come here. All we're concerned with is the underserved community. That's it. We believe this stuff. It's a sickness. So if you want to be a part of this, we will help you get in here. We will give you a rotation, do what you need to do. In fact, if you stay here and continue your academic, adventure, we're creating, we have a whole medical education department now, and it's all for the underserved community. Altamed's its mission statement is to eliminate disparities in healthcare access and outcomes by providing superior quality health and human services through an integrated world-class delivery system for the Latino, multi-ethnic, and underserved communities in Southern California. If you come to corporate, you'll see it splattered right on the floor in marble. And we really believe in that. But we want to help you. We want to reach out to you. We want to make sure that you have all the resources that you need, because you're a very powerful person. And we want to make sure to foster that. I don't know, Gloria, if you have anything else to add to that.
No, I second that, all of it.
All right. Well, we wanted just to say thank you so much again for the thought that was put into and all the work put into this presentation. Gloria, thank you again. And Dr. Angulo for sharing your personal stories and personally what you go through at Altamed. And I know Dr. Chinchilla had to leave soon, but we just wanted to say thanks again. And in the fall, we're planning to have another webinar talk with Dr. Terrence May, so be on the lookout for that. But thanks again for all those that attended and the speakers.
Thank you.
Everyone have a good night.
Have a good night.
Bye, guys.